Hi, in this lecture I'm going to talk about the pharmacological care of the patient who is experiencing heart failure. First, let's talk about the heart failure. What is heart failure? Heart failure is the inability of the heart to pump sufficient blood to meet the needs of the tissue for oxygen and nutrients. In the past, heart failure was often referred to as congestive heart failure because many patients experience pulmonary or peripheral congestion. You will see in a patient with congestive heart failure usually have lower extremities edema or crackles in the lungs, which is pulmonary congestion. Currently, heart failure is recognized as a clinical syndrome which is characterized by signs and symptoms of fluid overload or inadequate tissue perfusion. Fluid overload and decreased tissue perfusion result when the heart cannot generate a cardiac output enough to meet the body's demand. The term heart failure by itself indicates myocardial disease where there is a problem with contraction of the heart, which also is called systolic dysfunction or filling of the heart, and it is also called diastolic dysfunction. That both may or may not cause pulmonary or systemic congestion. Some cases of heart failure are reversible. It is depend on the causes. Usually, most often heart failure is progressive. It's lifelong diagnosis that is managed with lifestyle change and medication to prevent acute congestive episode for the patient. To adequately understand the pharmacological treatment of heart failure, it is very important to understand the causes and pathophysiology and clinical manifestation of heart failure. Also, there is two types of heart failure, and it is very important to understand the both types of heart failure, which is called right side and left side heart failure. Heart failure results from a variety of cardiovascular conditions, including chronic hypertension, coronary artery disease, congenital heart defects, and arrhythmia, as well as from conditions such as diabetes mellitus, fever, infection, hyperthyroidism, iron overload, hypoxia, anemia, and pulmonary embolus. These conditions can result in decreased contractions, which also is called systole, and decreased filling, which is called diastole, or both. Significant myocardial dysfunction most often occurs before the patient experiences signs and symptoms of heart failure, such as shortness of breath, edema, or fatigue. As heart failure develops, the body activates neurohormonal compensatory mechanism. This mechanism represents the body's attempt to cope with the heart failure and are responsible for the signs and symptoms that eventually develops. Systolic heart failure results in decreased blood volume being ejected from the ventricle. The decreased ventricular stretch is sensed by baroreceptors, sensors in blood vessels that respond to perfusion pressure of blood flow in the aortic and carotid bodies. The sympathetic nervous system is then stimulated to release epinephrine and norepinephrine. The purpose of this initial response is to increase heart rate and contractility and support the failing myocardium, but the continued response has multiple negative effects. We will talk about that later. Sympathetic stimulation causes vasoconstriction of the skin, gastrointestinal tract, and kidneys. A decrease in renal perfusion due to low cardiac output and vasoconstriction then causes the release of renin by the kidney. Renin then promotes the formation of angiotensin 1 inactive substance, which is an inactive substance. Angiotensin converting enzyme in the lumen of pulmonary blood vessel converts angiotensin 1 to angiotensin 2, a potent vasoconstrictor, which then increases the blood pressure and afterload. Angiotensin 2 also stimulates the release of aldosterone from the adrenal cortex, resulting in sodium and fluid retention by the renal tubules and stimulating the thirst center. This leads to the fluid volume overload commonly seen in heart failure. Angiotensin, aldosterone, and other neurohormones lead to an increase in preload and afterload, which increases stress on the ventricular wall, causing an increase in workload of the heart. This increases the filling pressure inside the heart, which in turn increases the stress on the heart by stretching the walls of the heart muscle, predisposing the patient to subendocardial ischemia. Patients with severe heart failure have constriction of the arterioles in the cerebral, myocardial, renal, hepatic, and mesenteric vascular beds. These result in increased organ hypoperfusion and dysfunction. Let's talk about the sign and symptom of heart failure. Systolic and diastolic share similar clinical finding. Obvious signs of heart failure include resting dyspnea, cyanosis, and cachexia, or physical wasting, resulting from long-standing heart disease. Tachycardia, which is the heart rate usually higher than 120 beats per minute, may signal worsening heart failure. When the heart rate is rapid, the stroke volume decreases because the ventricle has less time to fill. This, in turn, produces increased pressure in the atria and eventually in the pulmonary vascular bed. So, when you check the patient's pulse and get a weak, steady pulse, it is a sign of decreased left ventricular function. A baseline height and weight should be documented on admission, and weight rechecked each morning. Obtaining daily weights and tracking trends in weight along with an accurate intake and output log provide an easy and accurate way to monitor fluid balance. Fluid balance is an important surveillance strategy in controlling heart failure symptoms. Please make sure to watch the videos that I added to the PowerPoint, and you will really understand the pathophysiology of heart failure.